Let's start. The aim here is to understand how we can use all the devices in digital workflow. What happens is that we are trained for analog way, but when we started to work with scanners and OccluSense and many digital devices, we have a little bit difficult to understand how this device can put together to interpret the data. So it's what I will do here during the presentation. So let's understand how it's the system. OccluSense, it's an electronic sensor of pressure that register the contact, the occlusal contacts and their intensity. This is the aim and the core of the system, the intensity of the contacts, not only the contacts, but we can see how intense are these contacts. So it's formed by a hardware, the sensor, and the app that process all these data. And the core is here, the sensor. And let's understand what's different with this sensor. It's a very thin sensor with 60 microns of thin, flexible, that it's very important to modeling the anatomic teeth. And it's coated with a transferable color. This is very good because we can relate it what we are seeing in the app with the graphics and what we have in the teeth, where are the contacts, and we can relate it, these marks to analyze the data. And it has more than 1,000 points sensible to pressure. This is very, very sensible. And with each of these points has 256 different levels of pressures. So we receive from the system a lot of data. This is very important to understand because we need to filter and to know what we will use to interpret and to understand the reality, what is happening with this patient. So let's understand how this sensor works. We have two sheets with electrodes between them, these sheets. It's like a leaf, and in when they prepare this sensor, we have a lift, and then they close these two sheets with the electrodes between them. So we have positive point side here and the negative side to the other sheet. What happens is that we have electrons conducing by here, and when we have the contact between the teeth, we have the contact between these two sheets and electrodes, and then we have electrons going through this way. So the thinking and understanding how this sensor works, it's easier to understand how to interpret the data that they generate. What happens? That sensor has many areas, many bands to analyze the intensity. And when the sensor is between the teeth, and when we press this, we have the contact between the two sheets. When I have a more large surface touching this sensor, these sheets, we have the color of the column. Yes, it's the color of this represent the surface, the size of this surface. So if I have a punctual contact, I have a green, a red, and if I have more large surface, I have a more green color of these columns. This is the first thing that we need to understand. What is each information in this graphic. So the colors is the size of the contact between these two electrode sheets. And the height of this column is the intensity that this contact happens. So when these electrodes touch, they started to cross electrons through this system. If I pressed with a large stronger, I interrupt these electrons. So the system interprets this interruption as a high level, high intensity of this contact. So here we have the color, the surface, and what we are looking for in a good and an optimal occlusal contact, punctual contacts. Okay, I'm not looking for when I have a good occlusion contact. I'm not looking for large surfaces, large contacts, since punctual contacts. So what we are looking for are red contacts for a better ideal occlusion pattern. And more green contacts, I have more flattened contacts, more flattened anatomical surfaces. So this is very important. When I'm adjusting rehabilitation, for example, I'm looking to reach the red columns. And the same intensity between the posterior teeth with lower contacts, the intensity contacts in the frontal teeth, and then in the movement, we change this dynamic contacts. Okay? Until here, it's okay?
Yes.
And the system calculates the percentage of the intensity of these contacts through these bands that we have here. So, So we have 100% of the contacts, the intensity, and then the system calculates between both sides the difference between these intensities. So I cannot compare this graphic from one patient with another patient because I'm not using a reference, the same reference to calculate this intensity. The system is distributing the percentage between the contacts that patient in that situation, in that evaluation is presenting. Okay? So I cannot compare patients from these numbers. And let's understand the importance of occlusal contacts. The contacts happen only because we have muscle activity. Okay, if I don't have muscle function, I have no contacts between the teeth. I need the contraction of the muscles to reach the contacts, the contraction of the muscles to have teeth contact. So these contacts are responsible for system stability. If I have where I have these contacts tells me if I have a stable or an unstable position. And if I have a stable position, this muscle must not change the position all the time. So the muscle efficient, it's also another point of the contact distribution. So it's very important to understand that function depends on muscle activity. This muscle activity can result in balance or an unbalanced system. And this balance result depends on the adaptability of this patient. So it's more occlusal contact and how it impacts on the system. It's more complex than only see where these contacts are happening and the intensity and compare the sides. I need to understand how these contacts are happening. This is what we will see with OccluSense. OccluSense is a dynamic registration way, different from the scanners that are static. And we will have more information and different information with both systems. For this reason, I used to say that uh, many colleagues ask me, what do I buy? I should buy a scanner or a local sense for a better occlusal analysis. They have different purpose. They are complementary during our activity to get more information how the system is working. So for that, it's like a puzzle. Occlusal understand, it's like a puzzle. We need to understand the symptoms, where this system is unbalanced, which are the symptoms from this unbalance, and the signals of this unbalance of the system. So if you don't know what you are looking for, it's very difficult to recognize what you are finding. You need to have an idea how the system is working to know what you are looking for with the graphic and the information that this dynamic registration is bringing to you. So it's very important to understand if this patient has headaches, muscle painful, cracks, and so clicks and TMD. So we have to understand who is this patient, how is his function in daily activities. So it's very important to get this information, and then when you go to the patient's mouth, you can evaluate the signs from an unbalanced system. So which signs are these? Cracks, sensitivities, cervical lesions, non-carious cervical lesions, diastemes, movement tips after orthodontic treatments. All these signs are telling us that this system maybe is in an unbalanced activity. So then after all this information, you can go to understand and to try to understand how this system is working. And here, when we use digital devices, we need to make a changing on how we understand and interpret the data. Why? Because we were trained for analog work. We were not trained for digital device, digital tools. So how the papers work? This is a 200 microns thing. We have a glue here that transfer the color, the tint, and we have a larger surface because of the thinner of the paper. Here it's a paper with 100 microns. Look that it's the same occlusion, but the mark it's completely different because the thinner of this paper it's lower, and then we have a smaller surface, okay? And here it's the 12 microns papers. So we can see that we have this paper can modeling much better the anatomy, the tooth anatomy, and then we have only spots. These are the real contacts. from these teeth. How we use the papers? Normally, we combine a more thicker paper to transfer the glue from this paper, and then we can use this paper thinner that has no glue. But when we combine the papers, we have this tint coming to this glue. This is the technical to use papers from Bausch. We need to combine. Why? Because if I have a very glatt, glatt is in German, a very, oh my God, how is the word? Um, um,
I can find it out if you want to.
um, um,
It's a GLAT.
glatt is in Germany.
Yes,
In
but I
German.
can. Do
Yeah,
you spell it GLAT?
um, let me try in English. Glatt. Oh, let, sorry.
It's smooth.
Smooth, yes, exactly. If I have a very smooth surface, normally these papers, these thinner papers, doesn't work because the surface is so smooth that we cannot fix this tint, and so we normally combine. And how we can see these here? Look that I have the blue one here, and when I use the thinner paper, I have the surface. Here I have really not spot contacts pattern. I have larger contacts, okay? This is what the combination of the papers are showing us. But how to interpret these contacts with different digital tools? This is a challenge because when I make these marks directly in the patient, I'm I'm um, I'm registering the whole path from the movement that this patient makes to reach the maximum intercuspal position. Okay, this is a sum of from the beginning until the end, until this patient reaches the maximum intercuspal position. So if I ask you which teeth or which tooth touch first here, I cannot see this. I cannot tell you which, because this is the end of the movement. Remember that we have muscle activity to reach the contacts. The contacts only happen because of the muscle activity. And then here I have a sum from this movement. When I go to digital tools, what do we have? Here it's a mesh mixer analyze, and I can look and check the contacts with the meshing of the meshes. Okay, I have two meshes, static meshes, that when I register, I have these meshes. I don't have movement. I don't have ligaments, periodontal ligaments. I don't have muscle activity here. I have two meshes that cross, and then I have the contact. This is what we see with, for example, Mesh Mixer or Exocad. This is what we see here. And I can change this overload of these meshes to check the contacts that will happen if this patient put more force or less force. I can check this, I can change this. What happens with scanners, the occlusograms of the scanners? First is that I have normally a scale that is standardized for prosthesis space. This is very, very important, a very, very important observation. This is a picture from iTero, and look that the iTero comes from the blue one are from 1 centimeter, 1 millimeter distance of these meshes. This is a lot of space. 1 millimeter, it's a lot of space for contact, for occlusal contact. So when I look the contacts in an occlusogram from iTero, for example, I can only consider until 200 microns distance from these meshes. Why? Because here, what they are measuring the distance between the upper and lower mesh. It's not about movement. When I register, I have a position and the scanner registers this position. And then this occlusogram measure the distance between these meshes. So the red contact I have a crossover overload of these meshes, across of these meshes, and the orange contacts are contacts that goes until 2 microns of distance. So what we need to have in mind when we analyze occlusal contacts. The literature brings that normally we have a contact, but when we put force, I have the ligaments that absorb this force, and I have the muscle activity that contracts and then put these teeth in contact. But the teeth in real have no crossing between them. I have only contact through these surfaces. So what we are seeing when I have a crossing of the meshes here, this is measuring the ligament, periodontal ligament movement. Okay?
Right.
It's okay until now, until here.
Yes.
So what do we know? That this movement from ligament, it's about 100 microns. So if I have teeth against teeth, I have a possibility of 200 microns of this movement. So I can analyze until 200 microns from the occlusogram, the distance from these meshes. But if I am analyzing teeth against an implant, I cannot consider that the implant has this movement because there is no. So I have to consider that the real contact happens until 100 microns. Okay? This is
Yes.
a limitation when we cannot adjust this scale. This is really important. So, but if I have a periodontal disease in these teeth, for example, I will not have only 100 microns of movement. I will have more because I have um, no basement for this. And then I have more movement from these teeth. So to analyze the occlusogram from scanners, I must have in mind this, that I'm observing static meshes that and the relationship between these meshes were captured in a moment. It's a picture. It's not the whole movement. It's a picture from a moment of this movement. Different from papers that put all this movement in the same picture. It's like to add all these pictures and then I have a final picture. Here I have a picture from a moment from this registration, this movement. This is very important to understand because what we are trying to do, we are trying to compare what we are find with scanners and what we are find with OccluSense. But they are measuring and they are registering different things in different moments. I can find the moment that represents the scanner occlusogram with OccluSense. Okay, I can roll the graphic and then find this moment. But remember that when I register the position, I have to register both sides. And we will see the implications of this registration. So, and OccluSense gives us a dynamic registration. We can find, do we have a correspondence between these devices? Yes, I can find the right way, the right moment that these contacts are happening here. But remember that I need to look for this moment. So here I have habitual position, the maximum intercuspal position. And when I look here, this is what scanners register from these contacts. And when I look that, I can find these contacts here. I can find this moment. But what happens is that these contacts happen on this way. Look that. This contact don't happen equal at the same time. This situation, it's a picture from this whole movement. This is the difficult when clinicians want to use all together without understand what they are capturing with these different devices. Okay? And what is the second point that we need to have in mind? The intensity of muscle activity. If I have a patient, if I ask to the patient, please close, probably we will register this. Close, just close. Look that. Okay, but now I tell to the patient, please close with force. I will have this. If I don't tell you that these are the same patients, only with different commands, you will tell me these are not the same patient. Why? Because what I ask for the patient, how I register, how is the muscle activity of this for this registration changes completely what I'm getting as data. So I need now we will go back to the anamnese phase for the four phase. That is, I need to understand what I'm looking for. If I want to understand how the contacts are happening, I will ask to the patient, please just close, and then just close, and then this patient will not use a lot of force, and I can see more clearly the contacts happening. For example, on an stable, I can see starting here and going through here. But if I ask for the patient, let me see the final, how is stable the final contact, and I ask to go with the maximum force, I will see a completely different graphic. So this is very important to understand. If I have a patient with hyperactivity, hyper muscle activity for an unstable interference contact, this is very important because this muscle, it's not in the health the health condition, and then I will register. This muscle condition will reflect how we get this data. So for me, it turned very clear along the time using the system, because I can understand if this muscle it's not health, and I need to go a little bit slowly with a splint. It helped me. It helps me to make decisions more objective and more based for what I'm looking or what I'm seeing with the registration. But once more, I need to want to know what I'm looking for and give the command for the patients in the right way. And another point is, look here on this graphic that this contact don't keep the same intensity all the time. Why do we have this? Look that. I have the contacts happening, but look here that the contacts vary their intensity. The contacts are the same, but the patient is not able to keep all this contact in the same intensity. What is this? It's a fail of the device? No, this is the muscle activity that it's not able to keep this contraction for a long time. What do we learn from this information that OccluSense shows us? That when I capture with scanners, remember that I have to capture one side and then go to the other side. Maybe when I capture this side, I have this picture. But when I capture from the other side, I have this picture. Because this muscle contraction, it's not, this is physiologic. I cannot list, the system cannot keep this contraction for a long time. This is ATP source, and we have a cycle of this maximal contraction. Then this teaches that scanners have some limitations for this, because and now there is no better or worse device. They are complementary, and depends on what I'm looking for, which kind of information I need. It's the device that I will use to get that information. If I need to understand how the system is working, how is this distribution, how is the interferent contact, I can use OccluSense. If I just want to have an overview of the contacts, I can use scanners, but I need to understand how this device works to understand which will help me in that moment, with that information that I'm looking for. And another point is that if we have a stable or unstable intercuspation, maximal intercuspation, it's not uncommon. We receive patients that tells us, oh, I have one or two bites, different bites. When the patient tell you this, it's an unstable occlusion. And then what happened is that I register with OccluSense the contacts, and I register again, and I have a completely different graphic. What this difference is telling you that this occlusion is unstable. This makes a red light flashing, because you are in front of an unstable occlusion. Okay, so here, how do you see this stable or unstable? In stable occlusion, we ask to the patient, and the contact happened always at the same place. Open and close, open and close, open and close. Even I have different intensity of the contacts because of muscle activity and gonphoses and everything. The contacts will happen all at the same pattern. But if I have an unstable system, look that the patient bite, close in one place, and then I ask to close again, and I have a completely different graphic. So here I'm in front of an unstable occlusion. Then it's a very important information, depends on what I'm planning to do with this patient. For example, I will just change a crown. Okay, but in which position you will adjust this crown? You need to understand how the system is working to decide, okay, I will use this crown to stabilize this system. Okay, this is good, but I need to know for what, in which position I will use and I will choose to stabilize this patient. Okay, and the last one, it's the gonphoses that I told a little bit, but we can see here I have a gonphos. I have a movement from this teeth within the periodont, the ligament. If I have an implant, I have no movement. So I need to understand inclusive how I will adjust the final restoration when I have implants or different material, for example, zirconias, how these different materials, I'm using resin, composite, or I'm using zirconia. This will reflect different on this system, on how these forces will be spread through the ligament. For example, if I have a resin crown, this resin will absorb more from this force because it's the material is more resilient. But if I'm using zircon, for example, this is extremely hard, and all this force will be transferred to the root and the ligament. And so it's mainly in oral rehabilitation, OccluSense helps us a lot to make decisions based on the intensity of these contacts, and then delivery for this system a better balanced distribution of force, not only contact distribution, but the intensity of this contact. This is really, really important, and OccluSense for this make a great difference. Okay until now? Okay?
Yes.
Okay. So what's the difference of the OccluSense system? That it's the only device that registers the dynamic of occlusion. Then I can see the initial position of contacts between the teeth, how this contact will change during the movement until this system reaches the final maximum intercuspal position. And here it's an exercise to analyze what we can, how to interpret the data. Here it's a patient with a good relationship between the teeth, a class 1 here, class 1 here, relationship, class 1 here, class 1 here of canines, a good distribution, a good anatomy of these teeth, okay? Agree with me that it's a good anatomy? We practical have no restoration, composite restorations. And what I would expect from this occlusion, these teeth, a good occlusion, a good contact distribution between them. And what we really have, look here, we have very large contacts. What is the claim of this patient? Muscle pain, muscle discomfort. I'm always trying to relax. And why? Because these contacts are it's like it's physical law. If I have a large surface contact, I need more force to make movements, to slide between teeth. If I have punctual contacts, it's like a box. If I have a pound box over the floor, I need X force to move this box. But if I put four, oh God, if I have four pins, I need much less effort to move this box. So the surface, the kind of surface contact, it's important. It's very important. Sorry, because I forgot to turn my battery here. This surface, it's very important on the function and how intense it is. This should be this muscle activity to the system work. And here, what do I find? Do I get with the scanner? The same. It's the same picture. Look that. It's exactly the same picture. Here I have, and here it's from trios, occlusogram from trios. And here I can adjust the scale. This scale comes in 2 millimeters, and I can adjust this scale for 100 microns, okay? And then I have the contacts that are in blue, and the red ones are contacts that happens in 30 microns of distance. So what I will consider until 200 microns, okay? I will have the maximum force, and this contact will happen when this muscle contract. So here I consider 100, that it's a more refined evaluation. And then here, when this patient makes force, I will have this contact happening. So when I analyze OccluSense data, I will expect that these contacts will happen in green, okay, because the surface are very large, and these contacts will happen at the end of the movement, because at the end of the movement, it's the maximum force, the maximum muscle contraction, and then they will reach this contact. Okay, it makes sense?
Yes.
Yes. And here it's the same. I have the papers contact register, the sum of this movement, and then I have picture for a moment. And then it's very important that, okay, I'm getting a picture, but I can, from the distance, infer that this contact will happen. If we go to here, we will see that this contact happened. Okay? But it's not happening now. It will happen in a point of this movement, that maybe it's at the end of the movement with maximal force, because I need more force to get this contact. And when we analyze the OccluSense pattern, look that we have a lot of green contacts, a lot of green contacts. Why? Because the surface is large. And it's very important. If I ask you which of these contacts are more intensive,
we don't know.
Can I infer which contact here it's more intense? I cannot do that.
No.
Okay. And sometimes we have, for example, a situation that patient brings that only this premolar is sensible. He has a sensitivity on this teeth, on this tooth, and you say, why? When I check with papers, it's the same distribution. I have no first contact here, but when analyze OccluSense, we can understand how these contacts are reached. This is very, very helpful in some situations. Let's see. Look that. I have the contacts happening in different times. Look that. Until reach this pattern. So once more, if I don't know what I'm looking for, I'm not able to interpret these graphics. It's very complex. It's a lot of data that this graphic brings us. If I don't know, if I don't have a question, I don't know how to begin to interpret this data. And here it's a very, very important function that we have, that is the filter. Remember that at the beginning of presentation, I told you that we have more than 1,000 points of sensitivity, and each of these points has 256 different levels of intensity. This is the filter of that intensities. So if I want to clear, remember that when I put the sensor between the teeth, what happened? The sensor is flexible. So if I have a patient like this patient with a very detailed anatomic surface of the teeth, this sensor will need to model this anatomy. So I will have many contacts of this sensor. Remember the papers, that thicker, the thicker papers, I have larger contacts. So it's what happened here. If I have a very, very detailed anatomy, surface anatomy of these teeth, many of these contacts are not real contacts. They are the surface that the sensor is touching to model this surface, this anatomy surface. So I can use the filter to clear, and then I can correlate the contacts that we have in the mouth with the color transferring by the sensor, and I can filter this contact to see what I'm seeing with papers. Probably it will be this picture that we will see with colors in the teeth, because are the real contacts that are happening. Okay, and larger surfaces and punctual surfaces only some teeth. Okay.
Good.
And here it's lateral movement. This is very important because we can check if we have balance contacts during the movement. Look that I have This is, let me check if it's the right or the maximum intercuspal position. And then the patient goes to the right side, but we keep the balance contact, the balance side contact during the movement. This is very, very helpful because I can check if we have balance contact in the balance side and how is the intensity of this contact and how long these contacts last during the movement. This is a very, very rich information for joints health, for sensitivities. This is really, really important. Why? Sometimes we have a canine guidance, but we have this interference. And the patient, and you look, oh, this is working well. I have a guidance, a canine guidance, and it's pretty good, but you cannot see this interference in the balance side. And then normally I have seen this situation. I have a canine guidance, but the intensity of the contact in the balance contact, it's higher than the guidance. So the patient has a problem in joint, in temporomandibular joint, because of this interference contact. So this is really, really helpful to check and to show to the patients and to argue with this patient why this patient needs some specific treatment or some add. This is really, really important to communicate with the patient. Okay, until now, I will give you some examples how to apply in clinical situations. Until now, Steven, everything okay? Okay. Okay, Konstantin?
Yes, thank you very much. How do you correlate the contact on the system with the contact in the mouth? How do you know that? Can you say exactly which point on the tooth is the red point on the occlusals?
Through the color transfer. When you use the sensor has color, and this color is transferred to the teeth. And I can correlate this. It's exactly like a paper. I have the marks, and I can correlate that mark on the teeth, on the tooth, with the graphic.
All right.
You can do this correlation.
Thank you.
So let's see some clinical situations. For me, I have been using OccluSense since 2019. Since it came to the market, I'm a user really hard from the system. And for me, in oral rehabilitation, it's a must device. And I will show you the importance. I don't use OccluSense for all the cases I can use different device, a paper, or I can use scanners. I can use this for no detailed information in some case. For example, today I make an occlusal analysis for every patient that comes to me. How do I do that? In a digital workflow. I register the RP, central position, I register the maximum intercuspal position, and then I can simulate the movement exactly as we do in articulators, in analog articulators. I do this in a digital workflow. And every patient that comes to me has a functional occlusal analysis. And then normally I use OccluSense in some cases to understand this dynamic of distribution or some details. But for oral rehabilitations, in my practice, it's a mandatory device and using before, during, and after. And I will show you how I use that. First one is for provisional crowns. Here it's a case. This patient came to me because of teeth sensitivity, erosion because of a reflux, gastric reflux. But we have a crossbite, this periodontal disease here. We need to undergo orthodontic treatment, but the patient has a very important claim. Sensitivity and static were not good. And so what I did the whole process of functional occlusal analysis, the plan, the purpose of the treatment, and then I made the provisionals to start the orthodontic treatment. So I give conditions of periodontal here controlled, and then I need to move this to put this teeth in a better position to rehabilitate the static and function. And then I have no contacts between the anterior teeth in this phase, and I could improve the cross biting here, and then I have a reference to correct the curves, and so for the orthodontic treatment start. So what was the aim here with OccluSense on this phase? To improve the distribution of contacts. I'm not looking for a perfect contact distribution on this phase, because I will have teeth movements, I have changing all the time. But to start, I needed a better balance. So I got this pattern with no contacts in anterior teeth, because I needed this space to make the movements. And this is how we finish this case. All teeth controlled, good. This is a red with ceramic crowns, and this is the final distribution. Okay, this is a very balanced distribution of the intensity of the contacts. This for me, it's very important. And OccluSense is the only device that gives me this information. Normally, I go to this refinement after papers. I use the papers to adjust the contact distribution and get what is the ideal or the occlusal distribution. And when I look that and say, okay, it would be good, it would be finished, and then I enter with OccluSense, and I discovered that it's not finished. I discovered that I have different intensity of these contacts. This is very important, because when we finish our rehabilitation with this pattern, this is very stable, very, very stable, and I have no overload in any crown, any teeth, specific teeth, and this is very, very, very stable. This contact in a normal patient could be accepted, but for this patient, exactly on these teeth, I had periodontal disease here before, and this contact, it's not accepted. So I had to adjust. This is a crown, a ceramic, the distribution of resilience of this crown. It's different from natural tooth, and then I need to adjust this contact. This is the importance that I told you before about the material that I'm using. They will behave different when I have different materials. This is really, really important, and OccluSense can identify this. And here it's how I started with provisionals. Look that I have the same distribution, but I have a very balanced intensity between these contacts, and how we finished this case. This case is under control for 4 or 5 years, and we have the same distribution until now. This is 1 year control of this case. Look that I have the same distribution. This is very dynamic. Here before it's a static, it's a picture that I look, and this is how it's working. If I use more filter, I will get that distribution. Now I have more anatomy, and then I need to use the filter to understand and correlate with the contacts in the mouth. This is really important. Your question is really important. We need to correlate what you are seeing in the graphic and what we are having in the color direct in the mouth. And occlusal splints are another very important use for OccluSense. Why? Because I have this final adjustment of intensity, and another point is that I can control and show to the patient. If I have, for example, a patient that don't want to use splints, I think that it's not a problem of my clinic. I think that
No.
everybody has the same problem. Some patients really need to use occlusal splints, and they don't. And you need to educate this patient why this patient needs to use that. And show that if they don't use they will damage their teeth, and so it's a protection. So I can do this education process with OccluSense with splints. I can show them we adjusted. This is the final adjustment of your splint, and then we can make controls over the time, and we decide this period for each patient, and then we can show them that this first adjustment it's not kept because they have bruxism activity, and they are changing this contact, and it's very helpful to show them. Here I can show you the muscle activity importance to read these graphics. For example, here I have how I started the day 0 from the splint, and how I finish this day 0. Okay, Juliana, you have many contacts here? Yes, but I learned with the experience that normally these contacts are happening because of muscle hyperactivity. And normally when I wait and the patient use this splint for some days, this muscle hyperactivity it's going under, and then I will have a different distribution. So today my splints are all in the digital workflow. They are printed, and I have normally less adjustment than here I have. Here it's our acrylic splints, and then here I used to have more adjustment. And normally I didn't put so much effort to make this adjustment on this first appointment when I have hypermuscle activity. Why? Because after 30 days, this is the same splint without adjustment, just a muscle activity changing. This is really, it's really common. We see this in every patient that has hypermuscle activity. We see this pattern, this changing. So I wait for a time. It doesn't need to be 30 days. I can do this with 5 days. Some days before, after this patient starts to use splints, we have this changing. And then I do the final adjustment. And then this is a control. After 30 days and 30 days after 30 days after 30 days, I can show to this patient if this patient is stable or unstable. And then we can decide together. For example, for our rehabilitation patients, normally I finish with an occlusal splint because they arrived destroyed, and I don't know the role of bruxism on this process of destroying. And then I cannot affirm that all patients after oral rehabilitation should use occlusal splints. Maybe if I give to the system a stable position, a very good contact distribution, this patient has a muscle balance, and it's in a new phase of life, of stress. This is a different patient from the past. Maybe this patient doesn't need really use all the time, and so fix the splint. How do I know that? I need to control this patient. So at the beginning, this patient will use a splint, and then we will make these controls. And if we see that this patient is very stable, everything is going good, I can be more flexible with this patient. But if I check, I have a patient that I finished his oral rehabilitation with ceramics, and he destroyed. She's wearing ceramics. I have the scanners, and I show him, look how I finished your rehabilitation, and look how it's your ceramic now. You must occlusal splint use. This is not an option. If you don't do that, you will destroy the teeth again. We will lose all the work that we had. And this is very helpful to educate the patients with a very objective argue, and that it's not what I think, it's what we are seeing with data. This is really, really good, really important. This is the first, how this patient arrived after 30 days. I have this is a lower occlusal splint, okay? For this reason, it's a little bit different, the position of the contacts. This is a lower splint. And I have the contacts here, but look that I have some contacts from the vestibular cuspide from upper teeth. And so after the adjustment, I have only contacts from the palatines cuspide from upper teeth. After occlusal adjustments, after orthodontic treatment for us here in Brazil, it's very, very common and very need. Why? Normally for me, mainly, I attend mainly adult patients, and normally I receive patients with anatomy, tooth surface anatomy damage. And then at the end of orthodontic treatment, I need to reanatomize this surface to get the stabilization that we need and we intend. So this is very common here. And this is a case where we have ankylosis of some teeth and some movements we cannot do. For example, this premolar, this lateral, this central, we have some ankylosis, and we need to put these teeth in a better relationship to reanatomize the surface better at the end and get a better occlusal distribution contacts. So this is how the patient finished the orthodontic treatment. Look that we have less space between canines, better curves, but some teeth we could not move because of this ankylosis. And this incisor has a very compromised structure because of endodontic treatment. And these are the contacts at the end of orthodontic treatment. This is important. This is unacceptable. This is because the orthodontic treatment were not good, well done. No, because I have no good anatomy to reach and to stable, to get a stable occlusion. So look that for iTero, I consider only contacts until red and orange. Okay, the others are not considered because they have more than 200 microns. So I have a very, very poor contact distribution. Look that. I have no contacts here. These contacts are not well distributed. And then here it's a intermediated phase of the case where I reanatomize some occlusal surface. And then we get a little better distribution. You see this case until the end. And then this is the OccluSense at the beginning. A very, very poor contact distribution. It's aligned. It's with good curves, but with no contacts. And this is after the static phase for crowns. Here we negotiated the static for this tooth because the structure of this tooth is very compromised, and then we decided not to wear a lot of this structure to preserve. And then a good relationship between teeth, guidance, and now we are looking for a better anterior guidance. Here is the final after composite adding. It's lacking the premolar here. We have no premolar contacts. We have no anterior contacts. And here it's the final case where we have the guidance, the good distribution. And it's very important. Even I have some not perfect contact distribution during this adding composite, this reanatomized phase, because we do one here and one here. It's a lot of work to rebuild this occlusion. It's all made by hand and with minimal adds of strategic resins, but we will adjust at the end of the process. I use OccluSense not only to to check if I have not a very high contact, but the final balance I will adjust at the end. And this is what we got. Look, that a very good relationship between the cuspid, and these are the contacts distribution. And when you look here, you say, oh, this is 200 microns, analyze, and this is 100 microns, analyze. And when you look, you say, oh, maybe it's not so good as I expected. Remember that this is a picture of a moment, and I need to understand how it's happening with muscle activity and gone flows, is everything working together. And this is the picture of the final contacts distribution. A very good distribution, a very good intensity balance, and this patient is very, very stable until now. Ooh, the movements, lateral movement, right to the left, and go back, and then maximum intercuspation and protrusion. With no interference, everything working well. And this is the final case where we have a very good, stable, a good distribution and static rigid. So guys, this is all what I have. Here are my contacts.